Hi, I'm Dr. Selene Parekh, Professor of Orthopedics at Rothman Orthopedics. We're going to be talking today about Akin osteotomies and using the osteocompression staple for this procedure. Now, for most patients, they will have an Akin in association with some type of bunion procedure. And that bunion procedure can be done either with a lapidus or some type of metatarsal osteotomy. You can name whatever osteotomy you'd like to do. More often than not, with the open osteotomies, you're going to have some type of medial first MTP incision to deal with the medial eminence, the medial capsule, and performing a lateral release. In the situations where I have an open incision, I will extend that incision distally, typically about 1/2 to 2/3 down the shaft of the proximal phalanx. And so our incision for a Akin is usually the extension of the first MTP incision in this manner. But again, usually there's an incision that goes all the way proximal here to work on your first MTP. Now with that incision, we will first go through the skin. As we go through the skin, we'll want to get to the level of the capsule and the periosteum. I will typically elevate the soft tissues, superficial to the extensor tendons, superficial to the flexor tendon, but elevate the skin off the medial aspect of the phalanx. At this point, you can put in self-retainers, retractors, or you can use skin hooks. So we're going to get to the level of the periosteum. I'm going to extend this further proximally just because we would have done something on that first MTP. Now what we'll do is take this incision all the way down to bone, and I'll elevate the periosteum planarly as well as dorsally, and you want to make sure not to damage the extensor tendon or the flexor tendons as you do this. Now what I am looking for anatomically on a patient who I'm going to do an Akin osteotomy is the metaphyseal-diaphyseal flare, where the metaphysis dives into the diaphysis itself. That's going to be the level of my osteotomy, the proximal extent of my osteotomy. If you want to check radiographically, you can always put a marker here and check that radiographically for the level of your osteotomy. All right, these are the instruments you're going to find in the instrument tray. It will come with a impactor. This is your inserter, and we'll talk about that in a minute. You've got K-wires in case you want to pin your osteotomy prior to making your drill holes. You've got your drill pins, and then you've got your drill guide. This is an 11mm staple we're going to be using, but there's also a 9mm staple, and you can see the stamp on the guide to make sure that you've got the right guide that you need. At the tip or the end of the drill guide, there's these little windows, and these windows will help you to insert your staple if you choose to use this technique using the windows. This is the inserter for the osteostaple. There's two parts to it, two labels. One is where the legs are fully distracted, and the other is where they are compressed. And it has a nice positive stop so that as you're loading the staple, you'll know how far to go, and you can't go any further to distract the legs. Again, this is an 11mm staple. We will load the bridge onto the holder, and then we will distract it, the legs, and again you'll see that positive stop. You'll hear a little bit of a click, and that makes sure that your staple legs are in their parallel position. Typically what we're going to do here is we'll use the drill pins. There's a positive stop to the drill pin for the appropriate depth that you want to make your holes. Once you make the holes, you will remove the drill pins, and then with your drill guide in place, you can use the windows to guide your legs into the holes you made and to be able to deploy your staple. Now again, I will make my proximal aspect of my osteotomy at the metaphyseal-diaphyseal flare, and when I'm doing this, I'm making sure not to dorsiflex or plantar flex the osteotomy. My goal is to be perpendicular to the long axis of the phalanx. Now as I make this osteotomy, I'm trying to avoid coming out the lateral cortex, and so I'll try to touch the lateral cortex but not go through it. And one of the tricks we use is once you think you've gone as far as you want, you can see if you can collapse the osteotomy. And if you can, you know you are lateral enough. If you cannot, you'll put your saw blade back in and you'll advance a little bit further laterally to the point where you feel like you've cut enough, and then again you will check to see if you've actually gone through the phalanx enough to collapse the osteotomy. So at this point I'm going to make the distal leg or distal part of my osteotomy. When I do that, I will check the nail bed, and I want my osteotomy to essentially be parallel to that nail bed and meet my proximal osteotomy at the lateral aspect of that osteotomy. When you've done this correctly, typically the wedge itself will bounce out of the osteotomy. I always keep this small piece of bone because in case I've taken too much of a wedge, I can put this bone back into place and correct the overly sized Akin osteotomy. All right, at this point we want to close down our osteotomy. You're just going to hold the reduction where you want it. You can pin it in place if you want. If you have an assistant, they can hold it in place as well. And a lot of times I'll just hold it with my other hand. Typically what I will do is I will make my proximal hole first. Because I don't have as much real estate of the bone proximally, I like to put this hole where I want it. I have a lot of bone distally where I can put the second hole where I need to. At this point I can turn or swivel this drill guide where I want. I can make sure that I am in the center of the phalanx. I will hold it in place and I'll do my second hole. All right, so I've put all my drill pins in. There are two techniques to insert the staple. You can remove the entire drill guide and the drill pin and then just insert the staple directly into the holes, or we can use the window technique. With the window technique, you'll remove the drill pins. You will keep your drill guide in place. You'll insert the staple into the window of the drill guide. You can get this started, remove the drill guide, and finish off the insertion of the staple. I will open up the staple and that will allow the compression to occur. And then I'll impact the staple in place. At this point, you can close the periosteum and the skin. We really like the osteostaples because it avoids any metal, especially for patients who have metal allergies or prefer not to have any metal in their osteotomy site. Secondly, because this biointegrates over time, this implant will go away over time, and hence the patient will not have any soft tissue irritation or issues where the implant will need to be removed in the future.